Welcome to AETCM, the emergency medicine channel. Today let us discuss about one important muscle inflammatory condition, that is polymyositis. Polymyositis means multiple muscle groups are involved, that is polymyositis. It's an inflammatory myopathy which can present with acute weakness of muscles, especially proximal muscles, and severe tenderness. That is a classical finding. Whereas in other myopathies like diabetic myopathy, proximal myopathy, you can see that diabetic proximal myopathy, most of the time they are painless myopathies. Many congenital myopathies are painless myopathies. That means pain is less but wasting is severe. But here wasting is not occurring because it's an acute condition. After some months or years it can develop wasting, but it is severely tender. Sometimes it can be associated with dermatomyositis also. Dermatomyositis means some skin lesions associated with this polymyositis. Patient can have facial red rashes over the neck, red rashes over the chest. It can be seen on the extensor aspects of the hand and arm. So that is called as dermatomyositis. Now, the main group of muscles involved in polymyositis is large muscles, proximal large muscles, deltoids, hip flexors, abductors, extensors of the hand and leg. Sometimes weakness of neck flexors also can be seen. So, patient will have difficulty in sitting up and head may fall backwards. So, all these things also can be seen in many patients. So, flexion of the neck will be difficult, but whereas extension may not be involved. Now, there are different classes of primary myositis. That means muscles involved not secondary to infection. This is called as inflammatory polymyositis. So, there are, if you classify myositis into two major groups, one is infectious polymyositis and other one is inflammatory polymyositis. In inflammatory polymyositis, you can see it is a polymyositis as such. That classification is given in this slide, and sometimes it can be due to drug induced polymyositis, especially what you are seeing in statin induced myositis and all. So here polymyositis as such, that means inflammation of muscles secondary to some antibody mediated destruction of muscle, that is classified as polymyositis. That is primary idiopathic polymyositis, primary idiopathic dermatomyositis. Dermatomyositis, we already discussed that it is associated with skin rashes with myopathy or myositis. Polymyositis, dermatomyositis secondary to malignancy, especially lung malignancy, testicular malignancy or breast malignancy. So, patient, elderly individual who is coming with severe myopathy, myositis, we have to always rule out malignancy. Fourth variety is polymyositis or dermatomyositis associated with vasculitis. Various type of vasculitis we know, like small vessel vasculitis, medium vessel vasculitis. Like in that condition, if the patient coming with polymyositis or dermatomyositis, that comes under this group. Then polymyositis, dermatomyositis associated with collagen vascular diseases like SLE, scleroderma and all. So these are the classifications. So basically myositis can be due to immune mediated myositis, drug mediated myositis, infection mediated myositis. In immune mediated myositis, it can be primary or secondary to malignancy, vasculitis or collagen vascular disease. That is a simple classification of polymyositis. Now, malignancy induced polymyositis, many patients with dermatomyositis or polymyositis, malignancy is seen 25% of this type of conditions. So they also can have rashes and severe weakness. So muscle pain, tenderness and skin rashes also can be associated with malignancy induced polymyositis or dermatomyositis. Most common malignancies are breast, ovarian malignancy, prostate cancers, like that. Other malignancies are adenocarcinoma of GI tract, non-Hodgkin's lymphoma, carcinoma of pancreas and bladder. For adults with dermatomyositis, polymyositis, perform and perform tests to rule out malignancies, we can do mammography, colonography, prostate specific antigen, that is for prostate malignancy, and pelvic examination. So these all investigations should be done to rule out malignancy when we are dealing with polymyositis or dermatomyositis, especially in an elderly individual. Now, we have already discussed that differential diagnosis for polymyositis, dermatomyositis is polymyositis as such, that is mainly we are classified into three important groups. It can be immune mediated polymyositis, drug mediated polymyositis, or infection mediated polymyositis. Then diabetic painful proximal myopathy. Normally what you are seeing in diabetic proximal myopathy is painless and it's a chronic process. Patient will have proximal muscle weakness. But in some patients who is having high blood sugar, uncontrolled sugars, they can have asymmetrical proximal myopathy. That is always painful and it is tender. But they are classically asymmetrical, slightly more on one side and less on other side. Whereas painless myopathies are always symmetrical. Vitamin D deficiency also can have painful proximal myopathy. That can be seen very rarely, but vitamin D deficiency is very common nowadays, but we may not see in all patients who is having vitamin deficiency, we may not see the proximal myopathy. Very rarely only we see the painful type of proximal myopathy in vitamin D deficiency nowadays. Infections, in that most important condition in our country is leptospirosis or wheel syndrome. So wheel syndrome and leptospirosis, initially itself you can see patient will have severe muscle weakness, muscle tenderness, creatine kinase will be elevated. So polymyositis in our country, first differential diagnosis has to be leptospirosis. We have to rule out leptospira, especially when the patient is having fever, jaundice, renal failure, all these things. Now drugs like statins and other drugs we will see afterwards. Statins also can have moderate myositis. Now, how do these patients present to ER? They have severe muscle pain and muscle tenderness. That is very important. Severe tenderness is a feature of polymyositis. You can see here proximal muscle groups are more involved than distal muscles. All myositis proximal muscles are involved except conditions like inclusion body myopathy. In that distal muscles are involved. Otherwise, almost all types of myopathies, myositis, proximal muscles are more involved than distal group of muscles. So inclusion body myopathy, distal groups are slightly more involved than proximal group. Then renal failure is classically seen in many types of severe polymyositis because this myoglobinuria can occur that can produce obstruction the renal tubules and it can produce renal failure. So most of the conditions where there is rhabdomyolysis induced by this polymyositis can have elevation in the creatinine, elevation in the urea, elevation in the potassium. So potassium will be released from the distracted muscles, and when there is renal failure, that can aggravate. The potassium will not be released from the body through urine. So hyperkalemia and renal failure is very classical in most of the cases of polymyositis. Now there are lot of drugs can produce polymyositis. In that, most important is always HMG-CoA reductase inhibitors, that is statins and fibrates. Alcohol can produce polymyositis. D-penicillamine can produce polymyositis. Interferon alpha can produce polymyositis. Procainamide. Sidovudine is one important drug in anti-HIV medicine, can also produce proximal muscle weakness, wasting, tenderness, all these things. Then colchicine can produce polymyositis. Vincristine can produce. Chloroquine, hydroxychloroquine, they are used mainly in, these drugs are mainly used in skin conditions, malaria and all. We use chloroquine and hydroxychloroquine. Then amiodarone can rarely produce muscle involvement. Then emetin, then corticosteroids also can produce some types of muscle proximal myopathy. But corticosteroid induced myopathies are normally chronic myopathies. They may not present with acute severe myositis. but they present with proximal myopathy in a chronic usage. Now, statin can produce myopathy in various ways. It can produce myopathy, myalgia, myositis, and rhabdomyolysis. So, the various clinical features and definitions are given in this picture. Whatever it is, in most of these conditions, whether it is myopathy, myalgia, myositis, rhabdomyolysis, CK is one investigation which will tell you that the patient is going for rhabdomyolysis and renal failure or not. Most of the myositis, CK will be slightly elevated. CK can be elevated in 1000, 2000 in statins, but very rarely it can produce more than 10,000 in rhabdomyolysis induced by statins. And this rhabdomyolysis can produce renal failure also. It can elevate creatinine also. So, intravenous hydration is the treatment for rhabdomyolysis. We all know that, but the problem is statins are used mainly in patients who is having cardiac disease. Many cardiac disease patients can have cardiac failure also. So, when we are giving fluids, we have to be very careful because that itself can produce some fluid overload and pulmonary edema. So, when we are giving fluids, always make sure that we are giving adequate support by giving Lasix, that is furosemide. So, give fluids, give furosemide so that the fluid will be removed from the body, patient may not go to pulmonary edema. So, we have to be very careful when we are giving more fluids to prevent renal failure in rhabdomyolysis. Now, other investigation, like we have to see a complete blood count, because many patients who can have elevated count due to inflammation, and some malignancies can also be picked up by the counts. Platelet can be sometimes low. Then ESR, CRP, most of the myositis, inflammatory myositis, ESR and CRP will be very high. Ferritin indicates it's an inflammatory marker. It can be very high in patients who is having macrophage activation syndrome. Creatinine can be elevated in rhabdomyolysis, or in even leptospirosis it can be elevated. So, creatinine is an important investigation. Potassium can be elevated in rhabdomyolysis. So, potassium should be done. If there is associated renal failure, potassium can produce severe arrhythmias. So, we have to take care of that. LFT can be altered in many patients who have drug induced polymyositis, especially statin induced polymyositis. You can see elevation in the SGOT, SGPT. Urine examination, myoglobinuria is very classical. Some patients can have renal involvement, renal shutdown. So, myoglobinuria should be examined. Blood sugars can be very important, because diabetic proximal myopathy, blood sugars are very high. Asymmetrical, painful diabetic proximal myopathy can be there in some patients who is having high blood sugar. Then lepto-IgM is a very important investigation, because nowadays we get lot of cases who is having leptospirosis. So, you can see one important thing, that initially itself in leptospirosis, CK will start rise. So, any patient who is getting 1 or 2 IM injections, they can see CK will be elevated in 30 or 40 or 50 like that. But in a patient who is having leptospirosis, you can see classically CK will be elevated in thousands. That is very classical. So, lepto-IgM should be done. Other investigations like creatine kinase is very important in all patients who is having muscle injury. Normally in drug induced myopathy and all, you can see CK will be raised in thousands, like 1000, 2000, 3000, maximum 10,000. Whereas in polymyositis, dermatomyositis, it will be in lakhs, 1 lakh, 2 lakh, like that. And that should be done in patients, and you always have to do CKMB also. You can see the value of CKMB, that also will be elevated. That doesn't mean that patient is having cardiac disease. So, when the CK is elevated, there will be associated CKMB also will be elevated, but that doesn't mean that patient is having cardiac disease. And muscle biopsy is very important to know what type of muscle inflammation is going on. Anti-nuclear antibodies can be positive in 80% of the patient. Anti-Jo1 antibodies, that is myositis specific autoantibody. So, if we are getting very high CK, always do anti-Jo1 antibodies, that has to be done. Then other antibodies like anti-RO, anti-LA, anti-SM, anti-ribonucleoprotein antibodies also can be done. Electromyography should be done in patients to see whether any membrane irritability is there. Malignancy workup should be done in all patients. Like a male patient, you can do prostate PSA, ultrasound, prostatic biopsy, and testes should be examined, abdomen should be examined for ultrasound, chest x-ray. Some patients may require PET scan if you are not able to find out the focus of the malignancy. And female patients, breast examination, mammogram, and investigations like the thyroid ultrasound, thyroid function test, all these things should be done. And again, PET MRI or PET CT will be very good investigation to rule out occult malignancies. So that should be done if you are not able to find out the antibodies positive against to make a diagnosis of polymyositis. Now, cardiac workup should be done in all patients who is having this type of problem. We have to do ultrasound, echo and ECG. Pulmonary workup should be done, X-ray, CT scan to rule out malignancies. Pulmonary function test can be done because many of these patients can have interstitial lung disease also. Now, treatment in conditions like polymyositis, inflammatory polymyositis, like any other inflammatory condition, we have to give methylprednisolone. 1 gram methylprednisolone should be given for 3 days. Then prednisolone 1 milligram per kg body weight can be started, and you can taper over 3-4 months to a dose of 7.5 milligram alternate days. Steroids are chronic steroid use is not a good choice in polymyositis because that itself can produce proximal myopathy. So we have to go for steroid sparing agents. Initially we can go for cyclophosphamide, immunoglobulin or rituximab. They are all steroid sparing, or we can avoid steroids when we are using this type of drugs. So that can be tried. Then we can go for methotrexate or azathioprine or mycophenolate mofetil. Like that, immunomodulators can be tried. Now, follow-up of patients who is having polymyositis, secondary to immune-mediated polymyositis, methotrexate is very, very important drug, because if you are giving steroids, that itself can produce chronic proximal myopathy. To avoid that, we always switch to methotrexate. That's a very good drug. Azathioprine 50 milligram. Methotrexate should be given with folic acid always. Mycophenolate mofetil is another important drug that has got lesser side effect when we are comparing with methotrexate and azathioprine. Hydroxychloroquine can be tried in patient who is having skin involvement like dermatomyositis, but that itself can produce sometimes myositis, so we have to be very careful. Now, in statin induced polymyositis, it is statin induced myositis, we can avoid, sometimes we may not, we will not be able to stop statins because patient can have high cholesterol and problems due to that high cholesterol. We have to go for alternative drugs. We can go for ezetimibe or nicotinic acid, and other PCSK9 inhibitors like evolocumab, that is an injection, can be tried, and other drugs also given in this chart. These are drugs used for cholesterol. Whatever is given in this chart is mainly used for cholesterol. In that, except statins and fibric acid, that is fibrates, can be used in myopathies. So they may not produce myopathy like statins. So we have discussed about polymyositis. Polymyositis means almost all muscles in our body is involved, mainly proximal muscles are involved. We know that it can be due to inflammation, it can be due to drug induced, it can be due to infection. Inflammation can be due to again, it can be various causes. It can be primary inflammation, antibody mediated inflammation, or secondary to malignancy or rheumatological disorders or vasculitis. Whereas infection, the most common cause in our country is leptospirosis, and drug induced most common cause is always statins. So whenever we are starting statin for any patient, it is better to monitor the CK in all these patients. At least in a month you can do the CK initially. Then afterwards, if the patient is having no myopathy or myositis, once in a year you can follow up the case. Then one important thing is statin also can produce other side effects like SGOT, SGPT elevation. there are different types of statins. You have rosuvastatin, you have atorvastatin. Almost all statins can produce this polymyositis problem. But when we follow up this patient in a large patient group, we may not see much of the numbers. We may see 1 or 2 out of 100 patients. But when it comes to a patient, if you are treating the patient, better to stop the drug. If somebody is on statin and CK is elevated, SGPT is elevated more than 3 times, then better to stop the drug and go for alternative. So alternative is like you can advise the patient to do exercise, or you can go for other treatment also. Thank you.